Our speakers in order this morning are Kate O'Reilly, Professor Simon Walsh, who will join us from the UK, Gordon Gagney. We will then take a short break, comfort break of approximately 5 minutes or so. And resuming, we will have Professor Bernard Mahon, we'll have Paula Ryan, and we also have to speak last is a very talented singer, songwriter, musician, Moya Brennan, joining us to share her experience of singing to help with her breathing. So questions can be submitted via the chat function on the bottom of the screen, and these will be raised after each presentation. So, going to our first speaker. Our first speaker will be Dr. Kate O'Reilly, a respiratory consultant at the Mahon Misericordiae University Hospital. Dr. O'Reilly is one of the ILFA committee members and has been a great supporter to us in recent years, helping us with sound medical advice. So, if it's okay with you, Kate, I will hand over to you now.
Good morning, everybody. So thank you for that, Eddie. I'm Kate O'Reilly. I'm a consultant, as Eddie said, at the Mater, and I have had an interest in IPF and interstitial lung disease for a long time. Let me just, having a little problem with the slides. Here we go. Okay, so at this stage, Gemma might have asked me to talk to you about fire escapes or something like that. So I'm going to take on some housekeeping. Like most people, I'm at home, and I am hoping that one of these CATs does not appear on the roof or the garden, because we might have a bit of an episode of barking. So if that eventuality occurs, I apologize in advance and will run forth with my super soaker to try to get rid of the CAT. Okay, so overview of the talk today. I suppose I'm mindful that we probably have quite a diverse audience. Some of you will be very expert and know an awful lot about IPF, and other people listening might be less familiar with it. So I'm going to give some background, talk about current principles of management, and then talk a little bit about some things that have changed with COVID, and then go on to a little bit of what I see in the future happening with some more personalized medicine and some research. So I suppose I'm going to mention a lot about IPF today, but really this information is as relevant to other patients who have other forms of progressive lung disease. So let's start by breaking the term down. What is idiopathic pulmonary fibrosis, or IPF? So fibrosis means scarring, really, pulmonary relating to the lung, and idiopathic, unknown cause. And I've put a picture of a man's hand with a scar, and it is the same process that would heal a wound on your skin if you fell or cut yourself that occurs in the lung. But for whatever reason, and we don't fully understand it, the off switch, or the end of the scarring process, doesn't occur. So the disease is progressive. And it looks very like fibrotic diseases of the lung that may be related to known conditions like rheumatoid arthritis. The second thing I think it's important to cover is who gets IPF. And the simple fact is that anybody can develop IPF, but it is more common in adults of older age, and it's slightly more common in men. We also see it in increased numbers in people who smoke cigarettes or worked in dusty or industrial environments. It's usually sporadic, meaning that it occurs in one individual, and in certain cases, it does run in families, but usually it's sporadic. And one of the things that's very obvious as we look and register people with IPF around the world is that it's certainly increasing in incidence in the Western world. And while we don't understand that fully, the current thinking suggests that probably environmental factors play a big role, acting on a background of genetic susceptibility. I'm just putting, I know Professor Simon Walsh is going to speak to you, but this is a CT scan of a patient with IPF. And you can see here that the black areas here is reasonably normal lung because it's full of air. And these white bands, if you can see my pointer, are areas of scar. And if we took a biopsy of this area of scar, it would look something like this panel where we have dense scar tissue, so a lot of collagen. And this lung, as you can see, looks very, very different from this normal lung up above. So that is what really happens in the lungs as they scar. As the lung scars...
I didn't catch that. Could you try again?
As the lung scars, they get smaller, they get less efficient at getting oxygen into the blood. And some of the factors that we measure sequentially in clinic are the PFTs, particularly spirometry, which we measure the thing called forced vital capacity to follow the size of the lungs over time, and also a diffusing capacity to measure how efficient the lung is at getting oxygen into the bloodstream.
I didn't catch that. Could you try again?
Can we just talk about some key principles of management? The first one is, and the most important probably, is to maintain physical fitness. And similarly, you will have a talk from some physiotherapists later on who talk about that in a lot more detail. But maintaining physical fitness is really, really key. I mentioned that as the lungs get smaller, what we see is that patients will get breathless. And there are obviously that's because of the injury to the lungs, but heart disease can be an important contributor to lung disease as well, as can lack of physical fitness. So fitness is very important. And if you've been prescribed oxygen, it's extremely important to use it while you're exercising. Similarly, we want to maintain general health. We want to avoid infections like COVID. And certainly people should have a COVID vaccination when one is offered to them. And then we use some medicines to preserve lung volume.
Is there something else I can help with?
Always keep the quality of life in mind as well. So physical fitness, as I say, is number one on my list for a good reason. And a number of years ago, we were talked to by Professor Jürgen Baer, and he really brought it home to me very much, as he said, it's the one aspect of treatment that will actually make a patient feel better physically and psychologically. So that is hugely important. And as I mentioned, it's absolutely fine to exercise wearing oxygen, and you should do so if prescribed. On to the oral anti-fibrotic medicines. So these have been an extremely important advance in the treatment of IPF. And they work by slowing the rate of decline of the lung volume, this measure FVC that we follow. It's important to remember, however, that they do not reverse fibrosis. Side effects are not uncommon, and careful management of side effects, including dose adjustment, maybe treatment breaks, and using other medicines to help mitigate side effects are important factors that we take on board. But it is important to remember that about 30% of patients do not tolerate oral antifibrotic medicines. So a big advance, but certainly not for everybody. What changes have we seen with COVID? Well, obviously, due to the highly infectious nature of the virus, it's limited very much our capacity to see people in clinic, to attend pulmonary rehab classes, go to radiology for scans, etc. And maybe most significantly in the pulmonary function lab, the capacity has really reduced because doing PFTs is an aerosol generating procedure and can be risky for patients who are entering the room after another patient who might have had COVID, and also risky for the technicians. But two things that we've seen, and again, you're going to hear more about pulmonary rehab, but certainly in the Matter, we're conducting virtual pulmonary rehab classes. So patients who have access to a computer can actually attend the class, maybe not as much fun as attending in person, but certainly better than nothing. And we're also increasingly using the Patient Empower app with a handheld spirometer to measure FVC at home on a more frequent basis. And there's still limited capacity to do this, but the HSE has helped us and is helping with supplying spirometers and that for patients who are vulnerable with lung disease. So some positive things have certainly come out of the COVID. I'm just going to change tack a little bit now and talk a little bit about some research and the importance of that and how I see things going in the future. So one of the real challenges is that we understand that IPF is extremely complex, but we do lack a good understanding of individual patient differences. So as I see patients in the clinic, I have very little to guide me in choosing which medicine is best for which patient. And I don't really understand why certain patients do well and tolerate one medicine and the next person might not at all. So it really is time to get a little bit more personal with our choices. Okay, I'm going to tell you a story about a clinical trial that was done several years ago. It's called the Panther IPF trial. And it was very, very important for a number of reasons. So this was done in a very rigorous way. It was a double-blind, randomized, placebo-controlled trial. So very, very rigorous, high standards designed to answer a question. And it was initially a 3-arm study. So a third of patients in each arm. One arm was looking at triple therapy, which is really immunosuppressive therapy. Another was looking at the antioxidant NAC, and a third of patients were taking a placebo or a sugar pill. So the first thing that was very important about this study was that as you followed patients, we realized that triple therapy, far from being helpful, was actually harmful. So this arm was stopped and the trial was redesigned, but very importantly, it changed clinical practice because immunosuppressive therapies like steroids really then fell out of favor for treating IPF. And the finished study looked at NAC versus placebo, and it was a negative study. So NAC was not helpful. But on further analysis, the investigators realized that a small group of patients, 25%, did benefit from NAC. And when they looked at that specific group, it transpired that they had a certain genetic mutation. So this led to the creation of this trial called the Precisions trial, which is now recruiting patients in the United States. And to be eligible, patients must have this gene variant called a TOLOP-TT gene variant, and it occurs about 25% of US patients with IPF. So I'd like to see more of this in the future, where we really delve down and understand why certain patients might benefit from one medicine and others not. Last thing I want to mention to you today is a little bit about translational research. So I don't know if people have heard about the concept of the microbiome, but it is very popular in the popular press at the moment. And it really refers to the fact that we live in harmony, hopefully, with trillions of bacteria. And they really are found throughout our body, but most of all in our gut. And we know that a lot of factors can influence whether we have a healthy microbiome or a less healthy microbiome. And we've got some of these here, like stress, but I'm going to talk to you a little bit about diet today. So is it possible that diet can affect the bugs in our gut, and that might have a role in pulmonary fibrosis? Well, we certainly understand that a Western diet and a sedentary lifestyle are linked to cardiovascular diseases and to cancers. Certainly not suggesting that diet is a cause of IPF, but it is possible that manipulating the diet could have some anti-fibrotic and anti-inflammatory effects. And we certainly know that there are links between a healthy diet and a healthy gut microbiome. So one of the things that's changed in our diet is that we now eat very low amounts of fiber. And fiber can be found in two forms, soluble and insoluble, and I'll show you a panel of that in a moment. But soluble fibers actually help our microbiome, the bacteria in our gut, create things called short-chain fatty acids. And I hope, it's been a long time since I've done biochemistry, so I hope nobody's going to ask me about this in too much detail. But short-chain fatty acids, when they're in high levels, we were interested in studying in the lab whether they might affect fibroblast lung function. This is my friend and colleague, Dr. John Boff, who's a professor in the Conway Institute. And John is using these short chain fatty acids to treat some fibroblasts and see the effect. So this panel here actually shows what a fibroblast, which is a cell that makes scar, makes collagen, looks like under the microscope in the lab. And when these cells are activated and turned on, they make more collagen and potentially more scar like this that I showed you in the lung. And what the initial data shows is that while the fatty acids don't directly activate the fibroblasts, they do upregulate anti-fibrotic genes. So they potentially can be helpful. And I suppose talking about the second principle of management is maintaining good health and good general health. We all know that a high-fat diet is unhealthy, may lead to injury, inflammation, and fibrosis. So having a diet high in dietary fiber, creating more short-chain fatty acids through manipulation of the gut microbiome can be helpful and potentially have anti-fibrotic effects. Just to finish off by saying that we think about insoluble fiber, which is what keeps your bowels regular. And I'm talking about soluble fiber here. And here are some of the foodstuffs that are related to soluble fiber and insoluble fiber. So again, talking about general health, but also trying to understand more about how these environmental factors might influence pulmonary fibrosis. So in summary, IPF is a serious progressive disease. It's becoming more common. I mentioned that exercise, maintaining good general health, including a healthy diet, use of medicines in certain cases are the management priorities. While the COVID pandemic has been very challenging, it has created some opportunities to use more technology to care for patients. And finally, we really need very rigorous clinical trials and translational research so that we increase our knowledge and keep developing new personalized treatments for patients. So I will stop there and I will.
We have plenty of questions coming in, Kate, if you have a moment to answer them. Shall I read these out for you, Eddie? Is that okay? Yeah, okay.
Yeah, and I've had a few come through as well from Nicola.
Yes. Well, first of all, I'll read these two that just came in to the Q&A box. One from Eamon. On average, how long does it take to go from moderate to severe in IPF?
Eamon, that really is an impossible, it's a great question, but it's impossible to answer. So there are huge individual variations with patients. There really are. And while, you know, the big studies will generalize and say that, and I had a question about, you know, why is the life expectancy of IPF quoted at 3 to 5 years? And that's because in general, historical data suggested that. But as I always tell patients, unfortunately, some people die much sooner than 3 years, and lots of patients live for much, much longer than 5 years. So it is really, really difficult, and it is totally individual.
Andrew comes in with a question. Any genetic connection between different types of fibrosis?
Does that, I'm not sure if that question relates to fibrosis from IPF or other diseases.
Andrew might come back in the chat box
and
confirm that.
I also had a question here. Should people take vitamin D to protect themselves against COVID-19? And that's kind of a topical question, so I might answer that.
Yes, please.
So the data actually shows that vitamin D doesn't actually protect you against developing COVID-19, but if you have good vitamin D levels, you tend to get less severe disease, okay? And I was also asked, following on from that, is it best to just take an over-the-counter supplement or best to check with your GP or pharmacist? And of course, being a doctor, I would say it's always best to check with your GP or pharmacist, because there are certain conditions like sarcoidosis where you don't want to take too much vitamin D. So always best to check, but certainly through the winter months, taking a supplement is not a bad idea.
And I know there was a lot of questions that came in that went up on the chat box there, so I might read out a couple of them again for you there, Kate. Have no, I can't say the word, pulmonary fibrosis patients received the vaccine, and how had they reacted afterwards? Could it make patients' symptoms worse? Great question.
So yeah, great question. So absolutely, we know in certain US states and in the United Kingdom, they've now vaccinated large proportions of the population. So certainly pulmonary fibrosis patients have received the vaccine. The side effects that you might expect with the vaccine would not be expected to be any different than in the next person. So I would definitely recommend unequivocally that patients should have the vaccine. We in the Matter, and indeed some other Irish centres, contributed data to a paper that actually showed that COVID outcomes are worse in patients with interstitial lung disease. So having fibrosis or an interstitial lung disease puts you at higher risk of having severe COVID. So absolutely, we would encourage vaccination.
And Andrew came back and just said genetic connection, for example, between IPF and cystic fibrosis. So
they're completely different. That's a great question, but they're completely different. Genes are certainly, involved in both diseases, but they are different, entirely different genes.
Yeah, thank you, Kate. I'm aware that you have commitments this morning in the hospital, so thank you again for a very interesting lecture. Thank you. Our next speaker is Professor Simon Walsh, a consultant radiologist at the National Heart and Lung Institute and Imperial College London. Professor Walsh spoke at the ILFA Fergus Goodbody lecture in 2020, and we are delighted to be able to extend a warm welcome to him as he addresses us today.
Great. So first of all, I'd like to express my gratitude for having another opportunity to virtually lecture back in Ireland. I'm Irish trained, but unfortunately I'm over in England now working in Imperial College. I'm a thoracic radiologist, but I'm also a computer scientist, and so my research and my academic work is sort of straddling the areas of medical imaging and medical imaging analysis. So what am I going to talk to you about today? Well, I want to address some of the key questions that we face as imagers in fibrotic lung disease in 2021 and hopefully in the coming years. So we've seen high resolution computed tomography or high resolution CT in the last lecture. And this is central, this imaging modality is central to fibrotic lung disease assessment. So on the left here, I have an example of a CT showing normal lungs, and on the right, a patient who has IPF. Now, because of this, the radiologist is pretty central to the whole diagnostic pathway in patients suspected of fibrotic lung disease. And when the imaging appearances are conclusive, often the radiologist can make a definitive diagnosis and help the clinician decide on treatment. But occasionally the CT, probably more than occasionally, the CT appearances are inconclusive. And what generally happens then is that the case is discussed at a multidisciplinary team meeting, and possibly the decision to perform a surgical lung biopsy is made to further evaluate the disease. Now, the problem is that radiologists can misdiagnose fibrotic lung disease on CT, or the imaging can be misinterpreted. And this can be a problem because what happens is the patient has diagnostic delays. They may be exposed to an unnecessary surgical lung biopsy, and they may be exposed to treatments that might not be helpful in their specific condition. And actually, this disagreement issue, or what we call inter-observer variability, looking at CT, different perceptions between radiologists when they see patients with fibrotic lung disease, is surprisingly common. So we looked at this specific issue back in 2016, and we got a large group of radiologists from a number of international imaging societies, thoracic imaging societies, and we asked them to evaluate a cohort of HRCTs in the setting of fibrotic lung disease. Now, the study had 114 radiologists, but 91 of them were thoracic radiologists, many of them experts. And we found that when they applied IPF diagnostic guideline criteria to the CTs, there was significant disagreement on diagnosis. And it was strange because it wasn't related to the radiologist's experience. Now, it's not that radiologists are all hopeless, although perhaps some are. HRCT interpretation is actually really challenging. And we find that some radiologists see HRCT some way, others another way, and these differences can't be easily overcome with experience or training. So just to give you an example of one of the problems, and this is only one of the problems that we see. So on the left, you have a patient who has IPF, and you can see these what we would call honeycombing, but it looks like holes in the lung, and it's called honeycombing simply because it looks like honeycombing. Now, this pattern causes enormous difficulties among thoracic radiologists because of the different types of holes in the lung that we do see, not just honeycombing. So just to give you a quick example, in the cropped image on the left, top left, you can see that there are these sort of lace-like holes in the lung, and this is emphysema. This is due to cigarette smoking. Now, in the bottom image, you can see these thicker walled holes in the lung, and that's honeycombing. But in some patients, particularly patients who are ex-smokers, we can see these two patterns combined together. You see at the bottom of the image that there are these sort of semi-emphysematoid, we call them. It's sort of a cross between emphysema and honeycombing. And this particular issue can cause major diagnostic difficulties for radiologists. The other difficulty that we have is that we're interpreting imaging in 3 dimensions, essentially. So you have axial images, or cut through the middle, then you have these coronal slices, and on the far right, you have sagittal images, which are cut from the side. And this is actually quite challenging to sort of assess the distribution of fibrotic lung disease in these 3 dimensions. And as it happens, different types of fibrotic lung disease present with different 3-dimensional distributions. And these different fibrotic lung diseases may have very different treatments and have very different disease behaviors. So where does that leave us? Well, that brings us to exciting opportunities we have for applying computers to analyze images, specifically artificial intelligence technology and what we call deep learning. Now, before I give you a sort of a gentle primer on this technology, I want to highlight to you that all digital images are essentially numbers. So underlying the pixels is an objective truth. In other words, numbers that represent the individual different pixels within the images. And that means that these images can essentially be analyzed in an objective fashion using a computer. Now, just to give you a toy example, and this is the common one that we use in computer science. Say now you're trying to train a computer to tell the difference between a picture of a dog and a picture of a cat. What the computer does is it learns the patterns within the pixel data that correspond to a cat in an image or a dog in an image. And if you give the computer a large and diverse data set or collection of pictures of cats and dogs, what you find is the computer is able to then generalize to new images that it hasn't been trained on. In other words, you now have a system that can take new images of cats and dogs and distinguish between the two of them. Now, it turns out that this technology is really, really good at picking up very subtle differences within the images that really, really make a difference. So, for example, the image on the left is a white wolf. The image on the right looks almost identical to a white wolf, but it's actually a completely different type of animal. It's a type of dog called a samoyed. And it's really good at ignoring variations that are irrelevant. So both of these images are white wolves, but they're in completely different poses, and the lighting is different in the images. Now, bringing that back to HRCT, imaging of the lungs is no different. These images are also pixel data with those underlying numerical data underlying the images. And this approach to analyzing images has been applied to a number of different medical imaging specialties, in particular in ophthalmology for identifying retinal disease. There's a number of high-profile studies published in the last 3 or 4 years. In particular, Google have a huge interest in retinal disease and using this technology for generating rapid and cost-effective ways of screening people's eyes. So how can we apply this to patients who have fibrotic lung disease? Well, these are what I consider to be frontiers in imaging research in fibrotic lung disease. These are sort of the areas in which we really want to focus on going forward to improve how we use imaging to serve our patients. And I'm going to go through each of these. So we talked about diagnosis and the problems with diagnosis and inter-observer variability or disagreement between radiologists. And 2 years, well, it's 3 years ago now, we developed a deep learning or artificial intelligence application for providing diagnostic support in patients with fibrotic lung disease based on their CT. And we took our data from our big study of lots of radiologists around the world, and we compared the performance of the application to the radiologists. And what we found out of the 91 specialists, we found that it outperformed 60 out of the 91 thoracic radiologists in terms of diagnosis. And it also provided sharper prognostic information than most of the radiologists in that cohort. Now, one of the first questions I get asked when I talk about this is, are you trying to replace radiologists, or you're going to be out of a job if you keep going on with this type of research? But I would put it to you, there are fibrotic lung disease patients all around the world living in areas where there isn't specialist imaging expertise and they're not near tertiary referral centers, and they still need accurate diagnosis. And this type of software application is easy to deploy in these centers. It's cheap, it's reproducible, and it's consistent. And it essentially gives specialist level CT interpretation on tap to our patients. Now, the other area is drug development and patient safety. And I'm involved as a central imaging reader for a number of large trials of anti-fibrotic therapy. And the way these trials work in terms of the imaging is that a patient is screened, and I'll look at the CT and I'll decide based on criteria whether that patient is eligible to be enrolled in the trial. But you can see that if there is a problem with diagnosis and interpretation of CT, that this can result in difficulties in the trial. So for example, you can have imaging misreads, and what happens is you have increased screen failures, and drug trials tend to be, as a result, longer and more expensive. The third problem is screening or early detection of pulmonary fibrosis or biologically important fibrotic lung disease or patients with IPF. So, for example, in an IPF patient, on average, when diagnosed, these patients tend to be slightly older, but we do know that the disease is present before symptoms actually occur. So the obvious question is, what does early fibrotic lung disease look like on CT? So we do have some hints from the large lung cancer screening and cardiovascular screening trials, which have shown that some patients have incidental non-specific abnormalities on their CT. We call these interstitial lung abnormalities. And just from these images that I'm showing you, you can see these little patches of gray in the peripheral lung. Now, it turns out that there is an association between these limited interstitial lung abnormalities and all-cause mortality or mortality. So they are prognostically significant. But what makes this really difficult is the vast majority of patients who have these abnormalities incidentally picked up on their CT are stable and probably not important. So among all the thousands of patients that we potentially pick up with these little limited interstitial lung abnormalities, only a very, very small proportion of these patients actually have, it only represents significant early disease in a very small proportion. So this is a pattern recognition problem, trying to distill from the large numbers of patients who have these abnormalities, the ones that in whom they actually really matter. And this is absolutely perfect for AI technology, developing systems to be able to stratify these patients based on clinical risk. Now, the fourth problem Dr. O'Reilly mentioned actually is the issue of predicting disease behavior or outcomes. So we're tending to shift our focus to not just patients with IPF, but in a more gestalt way, patients who have progressive fibrotic lung disease, because they are not confined to patients who have idiopathic pulmonary fibrosis. And the problem that we have at the moment is we don't have any reliable way of predicting which patients will develop progressive fibrosis or remain stable using purely baseline information. So when they first come into the clinic, and this results in diagnostic delays, as we discussed, more lung biopsies, wrong treatments, and it's a big burden on healthcare. So deep learning or artificial intelligence provides us with an opportunity to potentially develop systems that can help us with this by finding patterns within CT, irrespective of the patient's diagnosis. So it doesn't matter whether the patient has a diagnosis of idiopathic pulmonary fibrosis or another fibrotic lung disease. We can use this technology to find patterns within the imaging that predict this progressive disease behavior. The fifth and final issue that we have is monitoring response to treatment. So if a patient comes in and they have a fibrotic lung disease, which is, say, progressing, analyzing the amount of fibrosis they have on CT, and then looking at their follow-up imaging to see whether it's progressed. Now, sometimes progression on CT can be incredibly subtle, but mean a lot to the patient. The patient has a lot of symptoms, or their lung function is showing that there's significant progression, despite relatively little apparent progression on CT. And we can use computers to pick up subtle changes on CT over time, which visually are inaccessible. So the radiologist actually can't detect the changes, but the computer can. So we can use this technology to track response or lack of response to therapy. Just to give you an example, here is on the left a patient who has a very limited fibrosing lung disease. This particular patient has what we would probably classify as probable UIP based on current guidelines, and a year after pirfenidone treatment. Now, they look very, very similar, but in this particular study, when they applied computer-based analysis to the imaging, you can see the yellow and green patches represent quantification of fibrosis. On the follow-up CT, there is definite progression that you wouldn't have easily picked up visually. Now, there is a lot of hype about artificial intelligence and how we apply it to medical imaging. I remember when we first presented the abstract for our deep learning application for diagnosis, this was one of the headlines in one of the papers after the Congress. Robots scored another win against humans, which is a little bit over the top. The point here is that we're looking to develop systems that can be used with radiologists, not to replace them, but basically diagnostic and prognostic support for imaging in fibrotic lung disease. And the other thing to mention is that together with Kevin Brown, who's a well-known physician from Denver and National Jewish, back in 2017, we recognized that in order to develop this technology, we needed to get huge data sets of essentially rare diseases, fibrotic lung disease, together to drive this type of research. So we founded the Open Source Imaging Consortium. It's now quite a big initiative. It's funded by a number of big drug companies, and among its members are a number of prestigious academic institutions around the world. And the aim is to develop large data sets to drive machine learning, computer-based image analysis research, specifically in patients with progressive fibrotic lung disease. So exacerbations, acute exacerbation on CT is something we do see, and CT is a very good way of evaluating this complication of fibrotic lung disease. And just to show you what it looks like, the two images on the left are a patient who has fibrotic lung disease. On the right, you see this increased gray in the lung, and this is essentially infiltrate or leaking lung. This reflects the acute lung injury that is occurring in the patient. So when we look for acute exacerbation, we look for areas of new, what we call gray lung, and I have a whole lecture on gray lung. And the reason for that is that there are a few other causes of gray lung in patients with fibrotic lung disease that I think are important just to highlight. So just to give you an example, this is a patient who has, again, an acute exacerbation of his fibrotic lung disease. And on the right, you see this gray lung. This was a patient who presented not that long ago to the Brompton where I work. But there are other examples of gray lung. For example, this patient has cardiac failure, and we know that patients with fibrotic lung disease can have cardiac decompensation. So this is something that you need to consider depending on the clinical presentation. Patients who have fibrotic lung disease may be on medications that result in them being slightly immunocompromised. So there are certain infections that can cause gray lung, in this case, pneumocystis pneumonia on the right. You can see these areas of gray lung. And technical factors. So if you have a patient who's lying on the CT scanner and they take a deep breath or a big breath out instead of in, when we're doing the CT, and that's not uncommon because these patients can be short of breath. You get these density changes because the lungs aren't inflated properly and they look denser or more gray than they actually are when they're fully inflated. So big deep breath in on CT when you're having your CT scan done is really, really important. And lastly, the one that catches everybody, if you give contrast to a patient with fibrotic lung disease, the contrast increases the density of the lung. So on the left is a patient who has very limited fibrosis. There's a fair amount of emphysema there as well, lots of little holes in the lung, but there's contrast on the right. This is a scan that was done to look for a pulmonary embolus or a clot in the lung. And we noticed that registrars in A&E, when your fibrotic lung disease patient comes in, if they're acutely short of breath, the registrar thinks, okay, it's a PE, I think we'll do a CTPA. They do this type of scan and they don't have a PE, but now the radiologist can't work out whether they actually have an acute exacerbation because all of this contrast is making the lungs look more dense. So what we do in that setting now is we do CTPA, but before we do it in our fibrotic lung disease patients, we take a few slices without contrast. So we have something to work with.
Yes, thank you again, Simon. So interesting. Our next speaker is Gordon Gagney. Some of you may know Gordon quite well as he delivers ILFA's weekly online pulmonary rehab class from University Hospital Limerick. We are enormously grateful to Gordon for his hard work, dedication and enthusiasm with the rehab classes that are of so much benefit to our patients. Thanks again, Gordon, for your support and from everyone at ILFA. So I'll hand over to Gordon here and now.
Good afternoon, everyone. I'm just going to try and share my screen there with me. I guess some of you know me already. My own name is Gordon Gagney. I'm a senior respiratory physiotherapist here in University Hospital Limerick. Thank you. With the help over the last, I suppose, 8 to 9 months, we've created a collaboration with ILFA, and we're happy to do so in providing kind of a routine national rehab exercise class. So what we're going to do today is talk about, I understand the patient information days from last year talked a lot about exercise and shortness of breath. So I'm going to talk about more in terms of muscle and the importance of exercise, kind of exercise recommendations. Also, because I'm running the national ILFA exercise classes, I'm going to go through that with people. I understand we have 110 participants today, which is great. So we're normally getting around 40 people every Monday. And if there's anyone on the call today, and if they want to access it, I'm going to go through how to sign up. And then also for people who can't attend at that specific time, I'm going to go through some patient resources as well that we, along with the students from University of Limerick, have created for ILFA that can be used at any time as well. So I guess all patients with pulmonary fibrosis will understand clinicians, especially telling patients the importance of exercise. But I think sometimes we don't tell patients why they're so important. So I guess this slide explains why we always harp on about the importance of exercise at any level. It's because as we do get older, whether we have a respiratory condition or not, our muscle fibers decrease. So once we get to around 30 years of age, we start a steady decline, unfortunately. And this is whether you have or you haven't a respiratory condition. So here in this graph, what I have is muscle fiber mass in our early life. Up to 30 is around here. It levels off at 30. And the upward line is basically a patient that remains active throughout the lifespan, whereas the lower line is where a person remains inactive. And neither of these patients have respiratory condition. However, as you can see, there's a sharp decline in the inactivity of patients, which has a massive impact on muscle mass and strength. And what we want to avoid from a healthcare point of view is where patients get into the disability threshold. And it's very difficult for patients to get out of this zone once they do get in. So this sometimes can happen if we have inactivity where we're in an acute setting for an exacerbation in hospital. This is why there is physiotherapist employed in the hospital setting, even when you're unwell, to encourage exercise. It's to prevent patients in reducing their muscle mass, and we want to increase ability and not create disability even when patients are unwell. So what is muscle mass or muscle wasting, or the medical term that we use is sarcopenia. So this is just a cross section of a thigh muscle. As you can see on the left hand side is a young healthy adult's thigh muscle. On the right hand side we see a sarcopenic thigh muscle. So where the muscle fibers have decreased, we've increased the amount of fatty tissue, but also we've reduced muscle mass. I suppose on a positive note, muscles respond really, really well at all ages to exercise. So this is why it is really important, whether you are able to do some exercise at the moment or not, it is to try and do it. And I know it's quite difficult at the moment during COVID-19 and during the pandemic. There's a lot of fear out there, but that's where we kind of created this collaboration thanks to Gemma and ILFA. And we wanted to create a kind of a habit for people who are cocooning, but also that they weren't missing out on vital treatment, basically. If anyone within the call or anyone starting exercise for the first time, we always get the patient to consult their GP or their clinician, whether it's their consultant, just to make sure that it is safe. So if you are enthused after this this call to start doing some exercise, we would recommend that you'd consult your GP or your clinician prior to doing so, because we understand that some patients don't just have a standalone diagnosis of IPF, they may also have other comorbidities. So it's just an important thing to do, and also it'll give you and your clinician a little bit more peace of mind starting a new exercise. What I pulled up here are the ACSM, so these are the American College of Sports and Exercise Medicine and the Center of Disease Control and Prevention recommendations for exercise. Now, it might look quite daunting because it is a lot of time. So each week, the recommendations around 150 minutes of moderate intensity exercise. This is where You might often hear your GP saying 30 minutes of walking, if possible, a day. Also, they recommend 75 minutes of vigorous activity and twice a week some muscle strengthening exercises. We understand that breathlessness can be an issue in this cohort, so we're not asking patients to do this. We're asking patients to, similar to the class that we run, there is a bit of aerobic and anaerobic exercises within that component, and it's perfectly safe for patients to use oxygen while they are exercising also. So at home, so thankfully with the pandemic, it's actually, it's been quite surprising from a physiotherapy point of view, how I suppose resilient these patient cohorts are, even in terms to technology. We didn't feel that maybe there would have been such an uptake in technology for older people, but in general, it has been fantastic. And because of here in Ireland with cocooning, or even with family working from home, we've kind of engaged family members to help out patients with getting online or getting resources online. And in fact, once they're set up, they're quite happy to engage. So from this point of view, it's been quite good, and we will probably use, even once COVID-19 does subside, we'll probably use a blended approach, because there's a lot of advantages as well. We've many patients that are traveling over an hour to do in-house pulmonary rehab with us prior to the pandemic, and this is an hour drive in and out, so it's a 2-hour drive, and it's a good bit of a burden for patients. Where we might use for those cohorts is exercise virtually. And it's similar to the classes that we run. On Monday with ILFA, we have roughly around 40 people every Monday, which is great. Beforehand, in person, we'd have only been able to get a maximum of 10. So this is really, really good. Also, in terms of if patients are doing any exercises at home, you can use very simple things, whether it's a plastic bottle of milk and just filling it with water and doing, and just basically whatever you have at home using as a resource as well for yourself. So you don't have to go out and buy any fancy weights or anything like that. So as I said previously, so with the help of Gemma, who's kind of the spearhead of it within ILFA, myself and Paula, who is our advanced respiratory nurse, she's going to be talking later. We run this class at 11 a.m. every Monday. Patients can contact Gemma or also email info@ilfa.ie to register, and it's done over the same platform over Zoom as well. So in terms of some patients will want some more information, or also they'll want to try and do this another time or another 2 times during the week. So with the help of students we have had from University of Limerick, we've actually created a YouTube video where it is basically an exercise class that patients and family can use as a resource during the week when the class isn't available. So sometimes this happens where people aren't able to be available for the 11 o'clock class. So this is a resource that you can use then in the meantime. It's just important to note, I refer to it as an exercise class rather than a pulmonary rehab class. Reason being is because the whole umbrella of pulmonary rehab is where there's an education component from a variety of different members of the MDT, as well as exercise. So obviously we don't have the education component at the moment. So it was kind of created more of a stopgap to kind of create a habit for patients while they are waiting for their local health centre or hospital group to offer them pulmonary rehab. And as is the case in ourselves, I'm sure it is the case throughout Ireland is unfortunately waiting lists have increased. And I think it's a good thing to do while people are waiting to be formally enrolled in a pulmonary rehab program, that they can actually do exercises in the meantime as well. So if you are offered pulmonary rehab by your local health group or your local I suppose centre, I wouldn't say, oh sure, I'm doing that already on a Monday. I don't need to do it. It's pulmonary rehab in general is a more encompassing program where there is also a lot of information given as well. So it's just important to note. So that's me. I'm very happy to take any questions as well from anyone. So yeah, thank you.
Is AI imaging in use in our hospitals, Simon?
Yeah, so I've been sort of answering questions while listening to the last talk. At the moment, AI in the specific setting of lung fibrosis isn't being used routinely, but what we are doing at the moment is we're running a clinical utility study to see the effect of our systems on expert and non-expert multidisciplinary team meeting decision making in patients with fibrotic lung disease. So we're gathering data to see how it actually works when deployed prospectively in a essentially a clinical trial setting. I would say that in the UK, I can't speak for Ireland now, unfortunately, but in the UK, there's a huge amount of investment in the NHS into AI technologies, and there's a lot of work being done to sort of facilitate rapid adoption of tools that are proven to work, because people are a bit hesitant about this technology, and that's good. It's good to be sort of skeptical until things are proven, but even when tools are proven, occasionally we find that there are lots of barriers to getting these things to patients. So we are working hard over here to try and break down some of those barriers, and I'm involved in some of the NHS England steering committee groups for sort of deciding on what we trial and what we don't.
Gordon, one of the attendees asked for the YouTube link. Can that be put in the chat box? So if you can do that.
Yeah, no problem. I'm just doing it there at the moment.
That's super. One asked, what is the safe heart rate when exercising on average?
So that's a difficult one. I suppose it's going to depend on the patient and what the resting heart rate is. And we also have a formula to what patient's maximum heart rate should be for exercise. In general, we look at, if you're starting initially around a 15 beats per minute of an increase. However, I suppose with virtual at the moment, we don't want to stress people too much. So we tend to tell people if they're getting a small little bit of breathlessness on the Borg scale, if they get to a roughly around a 2, we'd get them to stop. And I suppose that's the only disadvantage between virtual and face-to-face. Face-to-face, we can monitor a lot more. We can push people when we think that they aren't being pushed enough, or we can ease off when we feel we need to ease off. But with the exercise class we do on a Monday, we don't want people to be pushed too much, because we don't have that, I suppose, monitoring as we would face-to-face.
That's great, Gordon.
Thank you.
Okay, Eddie, I'll hand over to you.
Thank you, Justin. Our next speaker is Professor Bernard Mahon, Professor of Immunology at Maynooth University. Professor Mahon has previously spoken at one of our ILFA information days on research in IPF. Today, the hot topic is vaccines. So we look forward to learning more.
Great.
Thank you, Professor.
Thanks, Eddie. Let me see that I can share my screen. Hopefully that's coming up. Can you see that clearly?
Yes. We can indeed. Yeah.
Great. Okay. It's a great. Thanks, Eddie and Jammer and Nicola. It's great to be talking to ILFA again. Last time, really, we were speaking about. I was speaking more about research, but my older hat and some of the work I teach has been around vaccines, and in fact, I've collaborated with one of Simon's colleagues, the sort of fairly formidable and great Professor Peter Openshaw at Imperial, who we did some work on whooping cough vaccines. I've stripped this talk down a little bit, but at the end, if there are questions or you want to email me questions, that would be great. So I'm going to do a little bit of detective work. There was a plague in the city of Athens in the year 430 BC, which was well recorded by a historian at the time, who made this really quite impressive observation that sufferers who had recovered from the plague were able to work with the sick and dying without getting ill a second time, and not even getting ill, being completely healthy. So that observation is telling us something. It's telling us that somehow we learn about the bugs, the diseases in our environment or that are around us, and that we get better at treating and dealing with them. The second piece of detective work goes to the Faroe Islands, and in 1846, the island was struck by measles, and it decimated, as measles does, the population there. But a visiting ship's doctor noted that the over 65s, who usually you might expect to be more severely hit by an illness, seemed to be okay. And in fact, the sort of religious nature of this island community was that he was able to go through their church records and found that all the over 65s who had had measles at an outbreak in 1781 were completely unaffected, 60 odd years later. So this second piece of evidence is telling us that not only do we learn, but we also remember. So those are the two major features of the immune system that we exploit. Now, I've tried to keep graphs and figures and my favorite little diagrams out of this talk, but I'm going to take an exception on this slide. What's the basis? We know an awful lot now over the last century about why this happens. We have a phenomenally powerful system that we've evolved that means we can keep pace with the pathogens around us. So if we have a virus or a bacteria that can replicate, can double itself every 2 or 3 hours, you would think that we couldn't match that. But in fact, we can. We have a group of cells in our body, two sisters, if you like, the B cells, and these make a protein called antibody that is secreted into the blood and out onto the surfaces of the lung and the gut. And that really is very effective at killing free virus that are out in those fluids. And there's a beautiful system that means we have an almost infinite variety that we can create against that. So, we may worry or read things about Ebola or whatever, but we have a system that can actually match that and match the novelty. And more than that, we have a sister cell called the T cell that can look into other cells to see if virus is hidden in there and kill those. And that cell also, tragically, as we learned through HIV crisis, that cell is also involved in the sort of general coordination. And what that means translates over onto the right-hand side of this graph, that if we meet a new disease, a new microbe that's causing a disease, there is a very typical type of response. We have 5 or 6 or 7 days where you can't really measure any antibody. The body is holding the line while that system is being ramped up. And then very rapidly, the and it varies, obviously, that lag phase from disease to disease, but we get a response that goes, and it gets better and better, and that scale on the left-hand side of that graph goes up in all orders of 10. So there's a geometric, a massive response that comes in. And even beyond that, as the disease declines, the antibody goes back down, it never goes back to zero. We lay down a memory such that if we see that again, we come up with a very rapid response. There's no lag phase. We are primed and ready to go. And that's really what we exploit in vaccines. We give the body some exposure to either a part or a weakened version of the disease or the pathogen that's caused it, such that if we meet the real thing, we have that secondary powerful response. And that has had a remarkable effect. It's had an individual human effect, and it's had a societal effect. So immunologists, we sort of crow around how well we've done with smallpox. It's estimated that in the 20th century, 300 million people died of that virus. Yet we eradicated it in the 1970s through the mass vaccination programs. We've got rid of a disease called rinderpest, which is like a measles-like disease in cattle. 2 of the 3 types of poliovirus have been eradicated, and we are within a whisker, and we've been within a whisker for about 10 years of eradicating polio altogether. Just these pockets up in northern Afghanistan and Pakistan that are really still causing us issues. We know, of course, we can't point of who would have succumbed to smallpox, who would have succumbed to measles, but we know that the impact has been in the millions of people who are alive today that wouldn't be. And there are millions of and hundreds of thousands of people around who don't have paralysis, who have never had the severe diseases. But of course, we've still got major problems with TB, HIV, and malaria, and those are both scientific problems, but they're of such a scale that they lock countries and peoples into poverty and into a vicious cycle. So the disease makes the treatment worse, the treatment being poorer means that makes the disease, that enhances the poverty, and so on. So there's a big bonus to be had if we could solve any one of those big 3. I began my career working on a disease that's largely solved, which is a success, and that's polio. We forget how devastating polio could be, particularly in the summer months of an outbreak. This disease that seemed to strike almost at random, causing paralysis, having a huge impact on the survivors. 2 people really. We discovered the virus in 1908, but it was really in the late 50s that we worked out vaccines, and that was done by 2 contrasting characters, Jonas Salk and Albert Sabin. Salk on the right there took wild-type virus that caused disease and killed it and created an inactivated vaccine, whereas Sabin took similar strains but weakened them in the lab, and that took years, and finally got versions that could infect people but didn't cause the paralysis, and that became the basis of the droplets, the oral polio. And they're interesting because they are, first of all, there's a fascinating human story of these 2 remarkably different characters in fierce competition, but also their approaches have stayed with us. We've used both these sort of live attenuated versions of vaccines from Sabin or the killed vaccines of Salk for different things. I was going to go into flu, and I could go back into flu if anyone wants to talk about it, but but I have missed a slide somewhere. Here we are. So basically this slide looks at what are the tools that we have for our vaccines. We have a variety of different approaches. On the far right, we have Sabin's live attenuated approach. There are good things about that. In an outbreak situation of polio, that's the vaccine to use. The live virus protects the child that gets it, but also gives a booster to the mother. It hits this thing called herd immunity a lot better. It outcompetes the wild type virus. So there's a lot of good things about that. But the Salk, if you're at the end of a mass campaign, if you're almost got rid of the wild type, then you want to switch over to Salk's vaccine. It's cheaper, it's safer, but you need boosters. You have to use some clever additional pieces in there to make the vaccine a little bit more stronger, really, and last a little bit longer. So Salk's vaccine, or if you're having the flu vaccine, the flu zone vaccine would be a version of that. We then moved in later years to subunits, or just taking the protein. So we could take that blue protein there and use that as a vaccine, which hasn't been done for polio, but it's what we do for diphtheria, tetanus, pertussis, Hep B. The flu block vaccine would be that type of vaccine. Again, easy to store, easy to deliver. You can combine them in a lot more cleverly, so you have reduced visits to the clinician, but they take longer to develop. They can be quite expensive. You need these boosters and adjuvants to make sure that you get a good response from them. The last few years, we've seen two new sort of types of vaccines come in. On the far left, that one there, the recombinant, that's really like a Trojan horse. We take a virus that we all probably have, or have something that's really quite innocuous, something like an adenovirus, or an animal virus that can infect us but can't cause a disease, and use that as a Trojan horse. And we use some clever tricks to actually pull out any of the things that we might be worried about in there, and just put in a little bit of the signal that creates the program that creates the piece that we want, that blue protein in this case. And that's one approach. That should be a very good type memory, should be strong. But of course, you can't use the Trojan horse too many times. The body does learn how to notice that as well. And so if you wanted to, you're going to have to use a different type of horse each time, basically. And finally, the real recent ones have been to just use the signal, just use the nucleic acid. And we didn't think this would work 20 years ago. And then we started to see really from other fields that actually we could use this approach. The great thing is that these are very quick to design, very quick to change, very cheap, except we have to look at storage, can be quite a challenge. And we're still early days in this type of vaccine. So those are the tools we have. Now, I was going to go into a little bit about flu and some of the issues of that, but I'm going to skip that and cut to the chase that I suppose you're all interested in, which is, where are we with the COVID vaccines? So I've used the same coding at the top. There are different types. And then underneath that, I've given the various vaccines that are coming forward. If they're in the sort of brown color, it means that they're being used now in at least some countries. If they're in black, they're still in the clinical trials. On the far right side, really, the attenuated vaccines take years to make. There is a vaccine coming from the State Serum Institute of India, but that's still in phase 2. It would be a great vaccine to have in an outbreak. It would be great to use in a country with a poor infrastructure, but we're, I would say, you know, quite a way yet before we get that vaccine. The Chinese went very quickly for the Salk approach. And China has had a lot of bad press, but they did release sequences very quickly. And, you know, they learned some of the lessons from their SARS experience of earlier, and have moved to make 2 inactivated Salk type vaccines, the Sinovac and Sinopharm. And 50 million people have had those vaccines, and they seem to be working. Certainly the Sinopharm seems to be slightly better. They can be stored in the fridge. They seem to be effective, although there is still, I think, we'd like to see a little bit more public data from there on those. And China is using that very much as what's been called vaccine diplomacy, and giving that to, or making those vaccines available to countries that have asked them. The subunit type vaccines are really a little bit behind. We've got Novavax from Canada coming out with that, but that's still in trial. The Sanofi Pasteur Glaxo vaccine, which is going into phase 3, but they probably undercooked the amount of protein that they put in the phase 2, so they're having to boost that up a little bit. So, you know, the numbers haven't looked so good on that just yet, but by the time it gets to phase 3, they should have ironed out those problems. But those really aren't available to us yet. And there's some issues around how good they're going to be, particularly the Novavax against the South African variant. What we're seeing here really are the 2 approaches, the nucleic acid approach and the recombinant vectored approach. The 2 vaccines that have led the charge have been the nucleic acid and their message RNA, so they're not the same DNA that you have as the coding part of your cell. They're sort of more the intermediate machine code type pieces. You know, you're not going to get this vaccine and become something else. It's not going to interfere with your nucleic, you know, your DNA sequence or anything like that. The 2 vaccines that are coming from that are the Biotech vaccine, which is often called the Pfizer vaccine in the West, but Biotech have also licensed it to a Chinese company, Fosun. Works very well. Beautiful story behind this of a Turkish couple working in Germany, Shaheen and Tureki, which in 20 years' time they'll be making films about, but that's a romance for another day. The Madonna vaccine, virtually the same. There's a lot of really clever tricks in there. Basically, Shaheen and Tureki said that within 2 days of the Chinese releasing the sequence, they had designed the vaccine. And it's really, the whole year has been just taken up in doing the trials, manufacturing, scaling up. And they were very fortunate that they had already got their platform for delivery ready for some cancer therapies, and they just swapped the passenger inside to the spike protein of the COVID-19. The other vaccines are used, these Trojan horse types. It's the AstraZeneca vaccine, really, which is the one that is being made available in Ireland, or the Oxford vaccine. 2 doses with the genetic material to encode the spike protein, and that's being in an adenovirus that isn't a human. It's a sort of modified, what they call the Oxford version of a chimp adenovirus that I've been watching over the years, because they've been trying to use that in clinical trials for their TB vaccines and so on. So very safe. Again, they were fortunate that they had gone through so much of the safety data already. They just needed to change what was inside the Trojan horse. The Russian vaccine, there's always been question marks about the openness of the data there, but actually it should work. It's just a different versions of the virus of the Trojan horse. It's an adenovirus 26 first, and then a second for a booster with a different virus. And 7 million people have had that. But again, that won't be available to us. And finally, you know, this field moves so quickly. The Johnson & Johnson vaccine, which I had yesterday in my slides as being coming out of phase 3, it's the 1-dose vaccine based on an adenovirus 26. That's now been approved in the US, and, you know, achieving up to 90% efficacy. So really, we're looking in Ireland at the Pfizer and the Moderna vaccines, or the AstraZeneca, depending on which phase we're at, and quite which vaccines are being used at which phase is, I think, a matter of logistics rather than science. But we still have unknowns here. We don't know to what degree, well, there's sort of different stories in different vaccines, but are we protecting against the infection or against the symptoms of the infection? I think there's still some unknowns there. You know, are we stopping the carriage of the virus even if we're uninfected? Is it still in the nose or whatever? A lot of these vaccines are just hitting a very particular protein, the S, targeting that S protein. You know, the problem with that is that we might need a longer term, a more robust solution that includes some of the other components. And then the future, where are we going? Where will this be? Where will we be in 15 years' time with this? I think we already have, there are two things to be very hopeful about. One, we already live with COVID, with coronaviruses. There are 4 or 5 coronaviruses already that we probably have had as children, gave us runny nose type illnesses. You know, eventually the COVID-19 SARS-CoV-2 will end up in that family. But in the meantime, what do we do about the virus changing? Well, actually, the piece I've cut out, but the flu, we already deal with that in flu. We design vaccines year on year, and having got to where we have with the sort of array of vaccines that are up on this slide, you know, you could see in 2 or 3 years us having the infrastructure to decide, okay, we'll change the BioNTech vaccine, we'll tweak it in a particular way for next year's group, depending on how long we are protected with the vaccines that we get. So I gave a lecture 13 months ago in the university about this strange disease that was appearing in China and what we knew about it. And I think we've had an incredible journey over that time. At that time, I predicted that it would be 18 months minimum before we saw usable vaccines. And in fact, I was wrong. Tony Fauci from the States was right. We've done it much quicker than we could have expected. And that's not through cutting corners. What it has been is we've been very lucky in that we've had the platform vaccines that we just needed, that we already had a lot of safety data for, that we could just change very small components of. And then all our trials are really just looking for equivalents and so on. Or we've been, I think we've had to re-engineer our systems. So I know there are vaccines against TB and so on that have had to be put on the back burner as everyone has shifted and prioritized. And it's, I think, incredible that we've reached a stage that we have vaccines that work in, 13, 14 months. So I look forward to some questions, which Justin probably will read to me because I can't see them on my screen. But if there is any question you would like, you can email me at bernard.mahon@mu.ie, and I can give you the general immunology. I can give you some pieces around it. Obviously, I'm an academic rather than a clinician, so I can't give you, bespoke prescriptions or whatever. But I can talk in generalities. So, okay, thanks very much.
Thank you, Bernard. Mainly the questions are personal questions that are coming in, and I noticed Dr. Kate and Gordon and some other people at the panelists have been answering individually in the text box. But if you do have questions and they're personal, please put them through, and I guess, Bernard, you're happy to try and answer some of them.
Yeah, happy. And I can, as the screen has changed now, I can see that Kate has answered them exactly. The one you can get in your arm is the one you want. The best one that I would say, unless only in very rare, unusual cases, which probably don't affect us here. Okay, it would only be with sort of other conditions that and those people would probably have a very particular trajectory. So I think the one you can get is the one you want, really.
Thanks for that, Bernard. I know we're conscious of time, so I'll let Eddie introduce the next speaker.
Thanks.
Yeah, thank you, Professor Mahon. Very detailed and very knowledgeable. Thank you so much. Our next speaker is Paula Ryan. Paula is an advanced nurse practitioner at Limerick Mater University Hospital. Paula is a great supporter of ILFA and has spoken at patient information days previously, as well as helping with the pulmonary rehab classes. Paula has recently completed training in cognitive behavioral therapy with an ILFA educational bursary. We look forward to learning more about managing anxiety using CBT. So Paula, I'll hand over to you now. Thank you.
Thank you very much. I'm just going to share my screen now. Thank you very much. And again, I may take my opportunity to say thank you to ILFA for sponsoring me to do the cognitive behavioral course, because it was very informative, and I really believe it's kind of impacted it on our service, especially in our new virtual land during COVID times. So I'm going to speak a little bit about, 1 second, it's not letting me move, so I'm going to move my cursor down. About the symptoms of pulmonary fibrosis with patients, how we managed in University Hospital Limerick during COVID times, cognitive behavioural therapy, and again, managing our symptoms with the impact and I suppose of the support of the collaboration with CBT now in our clinics. I'm no expert in CBT, but certainly it has helped a little bit in our practice going forward. So the impact for our patients that come in with idiopathic pulmonary fibrosis and quality of life, and the three big things that we hear all the time from patients is that they're so short of breath, that it can become distressing and intense, that it does impact their quality of life, climbing stairs, getting dressed in the morning, having a shower, talking even, and that they feel like sometimes there can be a tight noose around their neck. Coughing can be debilitating and violent and exhausting. And usually it's a dry, hacking cough that our patients would complain of, but not necessarily always the case. It can sometimes be productive, but usually dry. And fatigue and tiredness also comes with that. I think patients are just tired from maybe coughing and shortness of breath and everything in life being that little bit harder and more difficult, so they can become quite overwhelmed with their fatigue and lack of energy and exhausted. And I think from a nursing point of view, I think these are supports, and we can support our patients and give them coping strategies on how to manage these symptoms. The impact IPF has shown on health-related quality of life. So health-related quality of life is significantly impaired in patients with IPF, and dyspnea and cough have been shown the greatest impact on their quality of life. But depression and anxiety is another factor that I suppose previously we didn't look at, but with pulmonary fibrosis evolving and changing in the last 10 years a lot, it's been shown now that depression and anxiety can be similar in patients with depressive disorders. So again, cognitive behavioral therapy is a really good key, and I suppose a part of our skill set that we can bring to our clinics now to support our patients. Physical functioning has a notable contribution to their overall health-related quality of life. And again, Gordon spoke about that, and movement for patients and exercise. Last March, when COVID-19 hit University Hospital Limerick in Ireland, everything changed for how we ran our clinics and how we managed our patients. I think previously we had patients that started on anti-fibrotic medication that would come into our outpatient clinics once a month for liver function testing and going through their symptoms, and we would deal with every symptom or anything that a patient was impacting their daily life, and we would deal with that in clinic face to face. However, that's really changed in the last few months. So what we're doing now is bringing in patients that are urgent appointments only, and we've changed to a complete virtual appointment with our patients. So be that over the phone, or if we need to see someone face to face, we're just using technology where we have a forward-facing device and we can ring a patient and maybe go through if we need to see them and talk to them, where we need to see the colour of their lips, for example, or see how breathless they are. New patients still need to come in, because I think there's a very strong education component that we need to give our patients on anti-fibrotic medication. And also on a personal level, I think it's very important for patients, if that's what they're happy with, coming in, because we get to know our patients when they start on medication. So we've a lot of information to give patients when they start medication. So getting to know them and building that relationship is very important for us, because we do get to know our patients very well. And in that, we foster a strong relationship with our patients. And then it makes the virtual appointment easier then, because when you're talking to a patient over the phone, when you know them well, they trust you to give their true symptoms. And also when preparing patients and family, we do let patients know that they have an appointment that will be virtual ahead of time, so that, for example, if it's someone that might get distressed by a call, that they have a family member available to them that might assist them with their call. We have had some challenges with getting bloods. With anti-fibrotic medication, we want patients to have liver function testing. So some patients have had difficulties where GPs may not want to bring people into the practice. So we've had some struggles there, but we've come around all of those struggles, and so we can get the liver function tests available for their appointment time. And we also allow time for discussion. I've noticed even in the virtual appointment that we nearly have more time for discussion, because we're able to spend more time talking to our patients rather than maybe writing notes, for example, and organising or disruptions in clinics, where in our office in outpatient department, where we've 3 doors, we've 2 doors at either side of us, and sometimes we can have disruptions, and like all of those disruptions can cause delays in an outpatient clinic. So I've noticed there's a lot of positives to virtual appointments as well. And what in respiratory nursing, from our point, we're trying to maintain a good quality of life for our patients at home, physically and mentally. So we're educating our patients on quitting smoking if they smoke, that they get plenty of rest, especially in COVID times, that they're keeping up with family and friends, that they have a good diet, that they stay active. And I found with some patients that because of COVID, they've become very deconditioned at home because they're nervous of going out of the home and walking. So again, it's just reminding patients that if they can go out for walks, and it is safe to go out for walks, but maybe just not to stop talking to people, but it is safe to go out for walks, because I think education is key here for people, so that they don't get depressed sitting inside all day. And movement is very important, and fresh air also. Practice relaxation techniques, and to join support groups. I think joining support groups is very powerful for our patients, and we have a support group in Tipperary and in Clare, and even with the joining of support groups, letting our patients know about ILFA. So usually when a patient is diagnosed with pulmonary fibrosis in our clinic, we would let them know about ILFA, give patient information leaflets, so that they can also link with patients through ILFA. So CBT, and as I mentioned at the start, this is a course I've just done. I'm no expert in it at the moment, but it is a very valuable skill that I'm hoping to grow over the next few months and years. But it is a combination of two schools of psychology, behavioral psychology and cognitive psychology. And it works on the premise that our thoughts affect behaviors and feelings, and that it is our thoughts make us feel bad rather than our life circumstances situation. So it's about, I suppose, the power of the mind and trying to think positive and be positive. And a variety of skills can be used for different conditions. So it can be brought in for pulmonary fibrosis. We were educated by 2 respiratory nurses in the UK that use it regularly with their COPD patient group. So just a little background of one patient I have used cognitive behavioral therapy with. Now, this is in collaboration again with a clinic as well. So a 59-year-old male patient who was diagnosed with IPF and on anti-fibrotic medication. He was an ex-smoker and a farmer, and his symptoms were cough and shortness of breath. And due to COVID-19, he was unable to leave the country, where in the viral seasons, usually he would go out of the country to a warmer climate, and had declined palliative care for symptom management. So the hot cross bun is just asking patients how they feel about their disease. And I think I'm over 15 years working in respiratory and the last 10 years working with pulmonary fibrosis patients. I sometimes think we don't stop to ask patients how they feel about their disease. We're educating, we're talking about pulmonary rehab, we're talking about medication, we're talking about sometimes inhalers and airway clearance, that sometimes we're given so much information that we're not listening to information back. So this patient felt that he could not catch his breath. He was afraid of stopping breathing because of coughing, and felt that he was isolated now at home due to COVID-19. He'd stopped family coming in to visit him, and he was scared, anxious and nervous for the future. And in all of that, we need to be able to identify how patients are feeling so we can support them in how they're feeling and educate them that maybe they can have family to come to visit outside, depending on restrictions at that time. This was before Christmas. I spoke to this patient. So at the time we weren't in level 5 restrictions. So it was about educating him onto how he could make his life a little bit more positive and bring family maybe outside, and they could have a cup of coffee more than 2-3 meters away from each other, just to make him feel positive and feel good. But we need to be able to identify unhelpful thinking styles as well. For example, afraid to go outside to go for a walk. That's unhelpful because we will decondition, and in that deconditioning, our lung function will deteriorate, and increase our awareness on our thoughts and behaviors. We want to replace and try to have some positive thinking and helpful appraisal. And I know the book from years ago, my brother used to always go on about it, The Secret. So is the thought the truth? Sometimes if you kind of think a positive thing, you might manifest it to make it happen. So it's similar stuff really, and it's about trying to use a positive mindset so that you can be positive and get up and get exercising and eat well, and just behavioral changes so that you have a good quality of life. And this good quality of life you'd aim to maybe improve and physical and social functioning at home. So physical changes can happen. Patients can get panicked, or anxiety has increased, and I've certainly seen that with our patients in our virtual clinics. People are really nervous. I was speaking to one gentleman who mentioned that he was really happy in COVID times that he didn't have to go to his GP anymore when he has chest infections, because he was nervous of even going up the street to his GP practice. So now he can just ring his GP and get antibiotics and steroids over the phone. And look, there's good in that, but there's also negative in that, because you're wondering, what if it isn't an exacerbation, or what if it isn't a chest infection, and then maybe overuse of antibiotics and steroids. So there's positives and negatives, but people are nervous and people are afraid to go out and meet other people when they have an underlying condition like pulmonary fibrosis. And sometimes if we look for something long enough, will we make it happen? So if we're afraid to go outside because we're so short of breath and walk a distance, over time, will we be more short of breath with that small distance because we've deconditioned? And when we're anxious or tired, things can feel more of an effort, so we can sometimes stop doing them. And when we stop doing the things that matter, our mood can drop, and we just feel like all of it can be a little bit of a waste of time. So it is important for us in clinic to be able to recognize these things and refer maybe to appropriate services. And if someone is very depressed or anxious, that we could refer them onwards. In our treatment of our patients with pulmonary fibrosis, we do, I think this is more in collaboration with cognitive behavioral therapy, but it's kind of in practice what we would do also is give a self-management plan, because everyone is unique with their disease and everyone's symptoms are unique to them. So education on their disease and disease management, comfort measures, and like that, if patients are very short of breath, the handheld fan can be really helpful that ILFA have. And the step counter, we would get patients to get the step counter so that they have maybe little challenges every day, especially now where they can, maybe if they did 3,000 steps yesterday, that they could aim to do 3,000 steps again today. Coping strategies for cough and breathlessness, so that, for example, if they were having numerous bouts of cough, that they would speak to us and we could talk on comfort measures, maybe little sips of water to try keep away their cough, or and different techniques that we would have that might help their cough and breathlessness. And in their anxiety and low mood, we could advise them to monitor their anxiety and low mood and see, especially now in COVID times, is it worse for them now, so that we can discuss that again and bring that up at their next appointment. And encourage patients to attend the virtual exercise classes that Gordon has already spoken about earlier. And I think it's quite powerful for patients, because not only are they exercising, but they're linking as well with friends of theirs at this stage all over the country who are doing the exercise with them. And the outcome from my patient that I did the CBT with is that the idea with CBT is that the patient comes up with more their self-management plan. So this patient required more education about disease again and wanted to talk about comfort measures. So he found that re-education had reassured him how to manage his symptoms better. He found that he was moving more out in the fresh air, and he felt better because of that. And he did start the weekly exercise program on Mondays. He felt that his breathing had improved, and seeing family via WhatsApp also. So helping patients learn about the disease can be quite empowering, because education is key to knowing how to manage your symptoms. And again, just looking at kind of good communication with patients with IPF, we do need to try and get the balance right. And in outpatient department, where it's really busy and we've got a lot of people traveling through, maybe to see a physiotherapist, see one of the respiratory nurses, go to phlebotomy, chest x-ray, see one of the consultants or one of the team. And it can be a challenge for us to have that time for patients that's uninterrupted. So just trying to get the appropriate content in the right time for the patient, in the appropriate format and context. And that's not only a challenge for us, but it's a challenge for patients that come in also, because they have so much to do in a 2 or 3 hour period. So they're quite breathless in that moving between phlebotomy, x-ray, maybe pulmonary function testing, and going down to maybe get a 6-minute walk test. So it can be overwhelming. So it's important for us to get that communication skill right for them, and know that maybe they are going to be traveling in their appointment a lot, because effective symptom control is impossible without effective communication. So that's it. And I just wanted to mention a few resources there with ILFA, the family carers, and also the NHS UK conditions on IPF also. And thank you very much.
Our next speaker is world-renowned Moya Brennan from Donegal originally. Moya will be well known to everyone for her incredible voice and extraordinary talents. We are delighted to extend a warm welcome to Moya and to look forward to hearing of her perspectives on singing with the help of breathing.
Thank you. Well, I'm very honored to be among such amazing professors and doctors and that, and I have nothing on my screen. It's just me. So I think Gemma got in touch with me to ask me, I suppose, just to talk about myself and how I'm kind of dealing with having IPF, and maybe to be an encouragement as well, that people that are out there, and how I've kind of what I'm doing and how I've dealt with it. And about it's probably about 3.5 years ago when I kind of noticed that I felt a kind of something sticking, you know. I had to keep clearing my throat all the time. And then by the summer, I was starting to cough a lot, thinking it was just, you know, just a cough or whatever that you might sort of develop. And when I went to the doctors, you know, I have a lovely doctor, and she said to me, she thought it might have been a virus. And so when I had an X-ray, she noticed that it was something else was there. So, you know, I went to St. Vincent's here in Dublin, and she, you know, and got a scan, and it showed up that I had some sort of scarring on the lungs, but they were still not sure. But I had a lot of touring to do. So I went off to tour. And my coughing did get a bit worse, and one of my faults was I wasn't resting enough. You know, I was kind of, I suppose, being on tour and singing and all that kind of stuff, you kind of you think you can do it, you know, 6 hours a night, or maybe even 5 sometimes, because you're so busy or whatever. And that wasn't helping. But the funny thing was that I was still able to get on stage. I had to clear my throat a couple of times during the concert, but I was able to sing. I had no problem singing at all. When I came back, about it'd be 3 years now, when my consultant, Dr. Emer, said they did a bronchoscopy, and this is 3 years ago. They told me I had pulmonary fibrosis. I had IPF, and as a singer, I was a bit shocked, and dismay, and you know, and thought, because I had looked up before this, you know, all the different things you could have. And my kids, they're in their 20s, but I still call them kids, but they used to say, "Oh, Mom, you don't have, you know, I don't think it's pulmonary fibrosis." So it was a complete shock. So the first thing I actually did was I canceled everything for up to 6 weeks, and I rested, and my cough helped a lot. I wasn't coughing like the way I was coughing over 3 years ago. It was a lot, just coughing all the time, spluttering, and you know, couldn't clear my throat and everything. And the rest was huge. I just basically did nothing, except for just a bit of walking. But apart from that, I also changed my diet. I was gluten-free, and but I went dairy-free, and sort of avoided processed meats as well, or processed food basically, and tried to buy as much organic stuff as I could, fruit and veg and that. So by changing my diet, by resting a lot, and doing a bit of walking. Now, I wasn't doing a lot of walking, I am now, but I just noticed that my coughing certainly improved. I still cough. I still have to clear my throat, but it's mainly kind of in the morning time, and then I'm sort of okay. But I continued to sing, and the more I sang, the more I felt it was really helping me, because when you talk, I think you fill your lungs a bit differently to when you sing. You kind of use your diaphragm down here, and you sort of fill your lungs in a different way. So, you know, I have kept singing, not long that, but last March, which is unfortunately was put to bed for a while, I was starting a farewell world tour with Clannad. And I think my consultant looked at me, thought I was a bit mad, but you just have to kind of go with it, and not look at, you know, what somebody mentioned earlier on about, you know, you see it written that it's 3 to 5 years. And that is something I don't sort of agree with, because I'm hoping to just keep on singing, because the tour has been postponed until either later this year, but or you know, and it'll go for a year and a half at least or something. But you know, I'm very optimistic about it. I have been like doing a lot of singing, because even though I haven't been touring or anything, there's been a lot of things coming through virtual wise, with virtual concerts which I've been doing, and singing on other people's songs and albums and different things. And I have a song out at the moment with a dance guy from Belfast, Transwax, and you know, I continue to do a lot of things. But as Paula was sort of saying about diet is really important, and exercise is really important, and that's two of the things. I mean, I'm very blessed to be beside Phoenix Park at the moment. We've sold our house in Dunleary. I used to walk out on the pier in Dunleary, but I go to Phoenix Park, and I would walk for 50 minutes. I mean, I would kind of, you know, and it's a good walk and everything. When I come back, you know, and I drink lots of warm teas. I don't drink ordinary tea. I drink lots of herbal teas and things like that. You know, and I take things like, you know, for inflammation. You know, you look up what you try and avoid, and what, you know, the sugar intake is very low now. Hopefully it's not completely eradicated, because I love my chocolate now and again, but very rare, you know, it's a treat. But also take things like, you know, turmeric and garlic and ginger juice I have every morning, and vitamins and things. So I just, you know, I've just looked at the whole, you know, my life, as far as, you know, what I put into my body and how I treat it. And I make sure as well that I do find it sometimes difficult to sleep. And you know, and also, you know, it's on your mind as well. You try not to let it be on your mind, but it is on your mind now and again, as far as what it is that you have. You try and deal with it. You try and stay as stress-free as possible. But you know, that's, you know, there's nothing that all these amazing people have been telling you that I'm telling you new, but it's just that maybe it's an encouragement for you to know that, you know, I've been diagnosed 3 years ago. I think I've had it for about 3.5 years. And I had been worse coughing, but with the rest and everything and just changing my diet, you know, I'm here looking forward to singing a lot more and touring a lot more. And so it's just, as I said, an encouragement to anybody out there to join a choral society, you know, when lockdown is down, but just singing. But even if you sing, you know, in your shower or whatever, just fill your lungs. And, you know, but I do think that, you know, I go for a breath test every 6 months. And I just spoke to them at the hospital the other day, and they were looking at, you know, the last January to last summer when I did the last breath test, and there was hardly any difference. One was 75% gone down to 74%, and they looked at that as being not really moving. So, you know, I'm thrilled, to the point that they said there was no need for me to go in to do a breath test at the beginning of this year, and I'll do one in the summer. So, you know, I think, Gemma, you were saying if anybody wanted to ask me questions, you know, I'd be thrilled to. But it's just, as I said, I'm here as much to encourage and just to keep doing all the right things, and you know, and sing along.
Thanks for that, Moya. Anne-Marie says, really interested to hear about Moya's experience of singing. Early research indicates improves well-being and sense of control of breath when she is taking structured singing for breathing programs. Would be really interested to know if Moya's approach to warm-up exercises or singing per se has changed.
My warm-up exercise, it's still kind of the same, just a little bit of warm-up, but it's really, I mean, because I'm not doing a lot of touring now, I'm working in the studio, which I have one in the house, and when I start singing, I tend to kind of start coughing a lot, you know, it kind of brings on a bit of coughing and clearing the throat and everything. And it takes maybe about 10, 15, 20 minutes, maybe sometimes less, whatever, to clear the throat. And then it seems to just settle down, and then I can continue several hours of singing or more, you know. And it would be the same when I'd be on tour. I would do a sound check. In the beginning of the sound check, I'd have, you know, after a little warm up, I used to really do that much of a warm up. But, you know, just a little bit of scales and whatever, and fill your lungs and holding a note and everything. But really you do a sound check, and that would be sort of just getting kind of what I would say, just kind of whatever, releasing something, or just getting rid of the just a bit of coughing or whatever. And then, I mean, during the concert, I would have to sort of just discreetly, you know, just move aside a bit and just cough a little bit in, or and I've also found, which was really funny, was when I was if the show was in two halves, I would come off and I would talk. We'd have 15-minute to 20-minute break. I would come off, and any talking that I would do, I would go back on stage, and it was like as if I was starting again. So when I came off, I learned that when I came off, even if I want to talk, I just sang everything. And then when I went back on again, it was like I'd already been there. So I just believe that, you know, that the way you use your lungs to sing is a bit different to talking.
Well, I think that was a very good series of lectures today, and I'd like to thank everyone for joining us today as well. I would like to offer my sincere thanks to all our speakers for their time and expertise. ILFA is honoured to have great clinical specialists available to participate in events, and we really appreciate what they do for us. It was a great pleasure to hear from Moya, and we're grateful to her for sharing her perspectives, and wish her all the best. I would also like to extend special thanks to Gemma for her hard work and dedication. Gemma is a great asset to ILFA, and I say these comments on different open days, but they are from the heart and they are genuine. Thanks again, Gemma. Thanks again to Justin for his expertise in hosting the online event. Always there, no hitches, brilliant, and thanks again.
Thanks, Eddie.
To my fellow committee members who dedicate their free time and talents to keep ILFA going, I'm enormously grateful to them for their hard work and commitment. We hope you enjoyed this Patient Information Day, and we will join you with another one in the not too distant future. If you would like to fundraise for ILFA, please get in touch. If you have a family member, if your family member is a member of a club or a society or whatever, please consider ILFA as a potential charity partner. We rely on charitable donations to continue our work, and all support is really very much appreciated. One more thing, I hope you did get our leaflet on the medicines and so forth. If not, let us know and we can get one to you. Thank you for joining us today. I wish you all a lovely weekend, and please stay safe.